Bueno, buenas noches a todos. Sean todos muy bienvenidos a este
Good evening. Good evening, everyone, and welcome to this first meeting organized by the Corners Fellows and Latambif Group. I'm Dr. Nicolás Zaderenko, and I'm the coordinator of the Fellows Corner. It's an area for teaching for SOLACI. The idea is to interact with all the fellows in Latin America. So here there's room for sharing cases through the platform, the product card platform, and in these meetings that we are starting today. So this is an idea that cropped up some time ago. It was Lucio Padilla's idea. He's the present chair of the Latambif group, and we thought it was interesting to organize these meetings completely laid back. The idea is to discuss cases live here. So we should all interact. So you are invited to interact. Probably there will be too many people. Maybe you don't have a chance to give an opinion, but anyway. So we'll do Q&A, we'll analyze cases, and we will listen to the opinions and the comments of the experts. Today, we have with us today Dr. Ignacio Cigalini. We work together in Fellows Corner, Dr. Marcelo Abud, coordinator of the Latambif group, the Latambif registry. And also we have two great experts, two speakers in complex intensivist procedures, Dr. Campos and Dr. From Brazil. They are friends of ours. I'd like to give the floor now, and I would like to thank you all. I would like to thank Evandro and Carlos for their participation. Thank you very much. Just one comment. This will be a broadcast in the networks, the Latambif platform, SOLACI platform, and Wonder. And there's simultaneous translation into English and Portuguese. Thank you very much, Nico. First of all, thank you very much. I would like to thank all the participants, all the attendees, more than 450 attendees online. We're trying to look for some special room for interventionists, cardiologists, and fellows wanting to participate in these meetings. This is just an initiative by Nicolás with the support of the Latin American Society of Interventionist Cardiology, and in this case also by the Latambif Club, coronary bifurcations. The idea is to also transmit and transmit to the world through a very important platform that's Wonder Medical. And every month or every 2 months, we will be presenting different topics, for example, here, coronary bifurcations, and we will be transmitting or broadcasting or discussing different topics. In this case, it's bifurcations, and we'll try and assess how to treat and analyze bifurcation with severe calcifications. In this particular case, we are going to present a case, a 65-year-old male with hypertension with a history of angioplasty in the right coronary artery, and at present he has angina with severe ischemia, complete medical treatment. So this is an angiogram showing the left coronary artery with a lesion, calcified lesion in the anterior descending artery with involvement of the diagonal. We can stop here and assess. We see diffuse calcified disease in a patient with angina and ischemia in the anterior territory. This is the first projection, antero-posterior cranial projection. This is another projection. This is the cranial view on the left side. I'll try to stop to visualize this anterior descending artery. It looks like moderate, but also a diagonal, an important diagonal. And here you can see also the calcium in this artery and the clinical picture. This patient has angina and anterior ischemia. So I would like to interact. Evandro, Carlos, what's your opinion? Here you can see the angiogram. Here, patient has a history of angioplasty in the right coronary artery. The first question is, Ignacio. Well, let's make it interactive. You can answer from the platform. So you saw the angiogram. What is the classification of Medina in this case? There you have the 7 options. Evandro, Carlos, maybe you would like to comment on that, what you are evaluating. Very interesting. The case is very interesting, Lucio. Congratulations for the presentation. What calls my attention is that this is a quite calcified lesion. We can see calcium on both sides of the vessel, predominantly on the left side on the screen. And it seems that this is a large lesion involving a large segment of the anterior descending artery and involves a diagonal, a significant diagonal, as Lucio mentioned. It's a bifurcated diagonal. However, there's a more critical point here in this segment lesion. However, the diagonal does not look so bad. I believe then that the definition, both based on the image or the intravascular image of the anterior descending artery to understand the classification and the plaque, maybe a functional evaluation on the lateral diagonal branch might help in planning treatment of this lesion, if it really requires a more complex two-stent technique or a simpler technique. Another thing here, by assessing the calcification degree, I think that according to the angiogram, it looks severe. So probably we need some preparation strategy for the plaque to have a good outcome and good expansion of the stents. Well, a large number of people here, 38% said is Medina 111, then Medina 110. Carlos, maybe you want to share your opinion. You want to tell us what Medina is, even though we are all supposed to know what that is. Lucio, good evening, everyone. Good evening, everyone. Good evening, Nico. Thank you very much for this invitation. Happy to be here with you, my friends, to share our opinions and our experiences. The anterior descending artery is very calcified. The diagonal is only one here, and it's very important. The Medina classification, it's a binary classification. 1, obstruction over 50%. 0, no obstruction over 50%. The first one is the proximal part of the main vessel, and the second one is the second part, and the third is the lateral branch. I think the diagonal has no obstruction, no significant obstruction based on the angiogram. It may be a plaque burden that's significant. 1-0. 110. The main proximal vessel, distal vessel, and I can see here that above the anterior descending artery, there's some plaque. The most important segment comes later on after the diagonal. And above, okay, exactly, let's watch the video. Good. So my idea is that the lesion in the anterior descending artery starts over above the diagonal is the most severe lesion, and the diagonal is free from significant disease.
Para você e para o Evandro, como esse aqui é evento para os fellows, eu queria perguntar para vocês. Com essas duas
For you too, the question is for you too. With these two projections that Lucio obtained, is it enough to assess this lesion, or do you need, or would you need some other image? Based on the angiogram, it's more than one projection for assessment. To see eccentricities, it's important to have more than one projection for assessment. I like the first one, the first projection Lucio obtained. It's a projection that I commonly use. It's the cranial, right cranial view. It's 20-20, 30-30. It's a projection that leaves the anterior descending artery well stretched. We can see the out track of the distal and diagonal vessels, and of course this projection to the left cranial area is very important because we can see the left main, the anterior descending artery, and the diagonals, the lateral diagonals, as Carlos said. Let's say we have to have as many projections as necessary that might be more visible in certain projections. I liked the two projections, so maybe we can have a good idea of the calcification, the distribution of the plaque, and we can start thinking about a strategy, an assessment strategy, and obviously after that, treatment. Maybe in the large clinical trials, it's more than 38% to determine when the artery is well calcified, when it's mild or moderate. What do you think? What do you consider about this calcification by angiography? Moderate, mild, severe. It's interesting to see the voting. Most of you think it's moderate. Some might even say, can you define when it is moderate, when it is severe, as shown in the angiography? The most widely accepted classification of severe calcification, as shown by the angiography, is when we see a circumferential calcification in more than one projection. If we see the calcium involving all the vessel and more than one projection, like in this case, we think about severe calcification. Exactly. This case, well, I think it's a severe calcification. Minimally moderate, slightly moderate, but because of the angiography, I would say it's a severe calcification. We can see the calcium before injecting, and then we can click this calcium movement during the dynamic images, and apparently calcium is on both sides of the artery, more than once. So it's a severe calcification, no doubt. The intravascular image will be useful, especially in cases when we have some doubts. In cases with less calcification, the angiography is less sensitive. We can be surprised with the intravascular image. when we see this calcification that can be more significant. Another point is the presence of nodes, calcium nodes, that can be more complicated, more complex than the larger complications. The intravascular image is highly sensitive to detect nodes, calcium nodes, and sometimes we can have to prepare the lesion more thoroughly, more carefully, to have a good, satisfactory angiographic outcome or result. Intravascular image, or I would need
certificar que la lesión
to
es
say that there's a severe lesion, and I would use FFR or IFR. Well, I understand that using the physiology for the anterior descending artery is not useful. As Evandro said, the use of the functional evaluation, the functional assessment will be very important for the lateral branch because it's an important, anatomically important lateral branch to guarantee an optimal result. In terms of the image, I believe that this is a spectacular case for the use of IVUS. Both IVUS and OCT help us quantify the calcification objectively. Both techniques, and IVUS and OCT, have scores, validated scores, to predict whether the stent that we're going to implant will hyperstretch or not. Both techniques have these advantages, particularly for bifurcations. I prefer OCT because we can assess easily. We are going inside with the wire in the proximal and distal part of the bifurcation, so we can assess with more precision, with more accuracy, and more easily. However, IVUS will also be beneficial because we will be treating only based on the angiogram. To complement what Carlos said, just a quick comment. OCT, Carlos is an expert in this field, has an advantage in terms of calcium. I don't use OCT so much, I do use IVUS, but an important advantage in the planning, assessment, and management of calcified lesions. OCT has the advantage of helping us define the thickness of the calcium. Sometimes we have this problem, this pitfall with IVUS because of the method itself. We can see whether calcium is just superficial, but how far is it? How far is it, let's say, rooted? It's hard to define. So OCT much better. We limit the depth, the extension, the thickness, and we can see that in most of the, I'll find what strategy, how to prepare the lesion. And this is a way to manage resources and then make angioplasty more efficient, cost-effective. I agree with Evandro. With IVUS, of course, calcium is superficial. Sometimes it's clear, then it's deep, but sometimes that's not so clear. With OCT, we can clearly see whether it's deep or not. We can see a fibrous layer from the calcium itself. And in this particular case, rotational atherectomy, if we have a fibrous layer, I can advance with a rotablator. Because of the differential slice, we can do the atherectomy, the rotational atherectomy, because the calcium is behind the fibrous layer. So a balloon, it's more interesting for calcium quantification. OCT is much more precise. We can see the volume of the calcium more accurately. I agree with the points Evandro mentioned, even more. This is, of course, we're talking about a bifurcation, but IVUS, coronary or intravascular images will bring about a lot of benefits. We can quantify a severe calcification based on IVUS or ultrasound, sorry. This is very useful to plan the procedure. Not everybody has these methods, these imaging methods available. We're in Latin America. There are other methods. For example, many people use stent boost or clear stent, depending on the materials available. Do you think this is useful? Can it be used? Any comment from the audience? We'd love to hear your comments. You just raise your hand and you can give your opinion. I would like to say, to sort of sum it, this is the strategy that I plan myself for this particular case. Radial approach, not femoral approach. I use 7 French with good support, with an extra backup. In this case, I try to use coronary guides to the diagonal and the LAD. We did IVUS assessment with images. And based on the calcification, I believe it's really essential for any procedure to see the plaque modification, the preparation of the plaque, to then give the adequate and definite treatment. And here I have some questions also, whether shall we use IVL, non-compliant balloon, rotablator, and then finally, we can use a provisional stent only in the anterior descending artery or in the diagonal or nothing versus the 2-stent technique. What do you think? What are your thoughts on this? Carlos, Evandro, Nacho, Nico, what are your comments? Well, as for the image, well, this is what I said before. I would use, no doubt, I would use the image. And I think that the stent boost helps, but it is the intravascular image. The image gives us much more information. I would use some sort of strategy to modify the plaque, but I believe the image can help us define the strategy. I would rather, well, because of a question of easiness, and if it's available, I would use IVL instead of a rotablator. I would keep the guiding wire in the lateral branch, as it happens with rotablator, and IVL is very helpful. In this particular case, I would prefer, as the ostium of the branch does not have a significant lesion, there's a bifurcation, an early bifurcation. It bifurcates into 2 arms of equivalent importance from the anatomy point of view. So I would use provisional techniques for the anterior descending artery, and I would protect the diagonal. I'm going to be honest. In my practice, 99% of the cases I treat similar cases with calcifications, bifurcations. So we plan, if we have to use a more aggressive plaque modification technique, the technical possibility of a 2-stent technique, I feel more confident, let's say, more comfortable if I use 7 French with an extra support catheter like XB or BU. And this doesn't, well, we can also use the radial approach. We can use the slender introducers, and very easily we can keep the radial axis, the real approach, without increasing the vascular complication rates. 7 French, that's it. A slender is an introducer that allows for a smaller diameter. 7 French helps me work with more confidently. If I have to treat a modification, I can do plaque modification. If the diagonal is involved, then I can modify the plaque, and then I can determine, because everybody, well, IVOS is not available everywhere. According to the registry in Latin America, 38% of the doctors use it in the left main. I'm not talking about the left anterior descending. So if we wanted to use intravascular, the IVOS, but it's not available everywhere. So the question here is quite practical. So what's happening in Latin America with these calcified lesions, the diagonal from modifying plaque modification in the anterior descending artery and the diagonal, and then see how the diagonal behaves. That does not seem to be severely involved. And then how do we modify the plaque with a non-compliant balloon? Then in Argentina, we have IVL. In Chile, IVL is available now. It's about to arrive in Brazil. Well, it's already here in Brazil. Not everybody in Latin America has these options. In Brazil, the problem is the cost. IVL is much more expensive than rotablator, at least in the hospitals where I work. If we use the rotablator, we have to use only one coronary wire and not a wire in the diagonal or the anterior descending artery. With IVL, we might have a wire in the diagonal and in the anterior descending artery. Rotablator would help us do the ablation, and IVL, because of the balloon type, because of the profile, the cross-section profile, cannot go to that calcified lesion. We have a question from the audience. Juan, are you there? We have a question from the audience. Well, maybe a comment, considering that intracoronary images are not available in Latin America. We have to be highly suspicious, and we have to prepare the plaque. In spite of not having the image, which would provide us a lot of information. IVL, rotablator, I can use those if I don't have IVL. Unfortunately, the most advanced technologies are more expensive. So we can use all these resources and not using them the best we can. Well, that's a waste. The advanced methods for plaque preparation like IVL and rotablator, they have to come together with the intravascular image so that we can obtain the best outcome, the best result with these techniques. So what about the intravascular ultrasound? What about IVOS? Well, this particular case, so as to move ahead a little bit faster, I actually tried to advance, as you see here in the image. I tried to advance with IVOS, but truth is that it did not advance. The catheter did not advance because of the calcification itself. So what do I do, Carlos? Well, as for the information that IVOS can give us, IVOS can quantify the calcification grade. Well, it's not, I don't know if the case I mentioned, how can we classify a severe calcification based on ultrasound? I don't know if that's relevant. I can make a comment on that anyway. But here, because of the angiogram, it's clear that the calcification is severe, but IVOS gives us information about the real length of the disease or the grade of the disease, and we cannot see that in other images. So distal and proximal we get a better dimension of the vessel, the proximal reference, the distal reference, and a better understanding of the carina, the diagonal and the anterior descending artery, which to see what the strategy could be. So in this scenario where the ultrasound catheter did not move ahead, predilation of the lesion would be a good idea, a good option. Honestly, I would start with a non-compliant balloon, with an NC balloon 3.0 for this particular lesion, and then I would do ultrasound to assess the calcium. Semi-compliant, I would use an NC balloon, non-compliant, 1:1 for the artery for a higher dilation pressure. The non-compliant balloon is, but I would, in this first approach, I would use high pressures without exaggerating in terms of the diameter. Well, some people here want to ask some questions. Can you send a question on the WhatsApp chat, please, so we can answer the question? Well, as you can see this, I'm commenting on the evolution, the intravascular image, the balloon, the non-compliant balloon 3.0 by 15 did not advance either. So I made a third decision, like plan C. What do we do in that case, Evandro? In the first place, we have to be careful so as not to break the catheter. We cannot open two ultrasound catheter in one case. We cannot. We can even see here some protrusion. It's a very fragile catheter and it may break, and then we won't have the methods available during the procedure. Some people say that the next step is rotational atherectomy. I have a couple of examples. Instead of fighting with the lesion, I use the rotablator. We make preparation, and then after rotablator, we can advance easily along the coronary artery. In my practice, I do not like to do what Carlos said, that is to say, balloon and then predilation. In general, I prefer to use a smaller semi-compliant balloon so that I can move the catheter and then make an assessment. One of the reasons why I don't like to do predilation aggressively and then do rotablator, I think the effect of rotablator is not the same. The plaque grip is lost somehow with dilation. So this would be a critical. I'm being critical here. In my next step then would be to use rotablator or do predilation 2.0 semi-compliant low profile balloon with a better performance to cross the lesion so as to open a path, let's say, and then advance with an IVUS catheter and perform a more precise evaluation. These are my two steps, depending on the availability, of course, of what we were planning for the calcium. I think there's a question from the audience about the use of cutting balloon. Otherwise, if we cutting balloon would not advance either. I think that this balloon would not be able to cross the lesion, let's say. Yes, probably not even the IVL would be able to cross the lesion. Well, the way I see it is that the deliverability of the shock wave is similar to the deliverability of an image catheter. So if the ultrasound catheter did not pass, IVL won't pass either. I think that the cutting balloon would not be a good strategy because the non-compliant balloon did not go through. Well, in 3 or 4 minutes, maybe, could you tell us how many seconds? Would it be short or long? And what about the RPMs? To make a more rational use of the materials, I would use 1.5. And then we could use cutting balloon to try and finally modify the plaque. My strategy is rota cutting for severe cases for the anterior descending artery. I think that the ultrasound, we could use it, but we can use 1.5 and then cutting. If resource use is not a problem, we can use different sizes according to the vessel size. Well, it's hard, but we can adjust the size of this piece. Rotation 160, I do 15-second runs, and then I observe the deceleration, not more than 15 seconds. And then after advancing through the whole, I could run the whole calcified segment and then do a final step. I would not run through, I would like to do a shorter run. So when the RPMs goes from 5,000, then you can stop and go backwards to prevent the obstruction. There might be a lot of embolization. We have to listen to this piece, and when it's becoming obstructed, we have to go back from less to more. See how the BP, the blood pressure is, how the patient reacts. This is from proximal to distal with shorter segments, 1.5, 15 seconds, and then how this behaves. We have a couple of questions here. Lucio, I think there's a question there about rotablator using bifurcations. Can we do that anyway without the diagonal? Didn't seem to, the angulation was good, didn't seem to be so severe. So probably there were no complications. And then we have 2 comments related to the advance. And then Martin Ferrucci from Argentina says that eventually we can advance a microcatheter or even do wiring. We believe that the calcification is severe. I would have done the same thing. I would like to make a comment about rotablator here in the first place. 2 comments. The first one, just as an educational point for the fellows, a very nice way to use rotablator is mainly the rota wire should be well positioned in the target artery. One of the tips I can give you that I also use in my daily practice I use a microcatheter. I believe that this will be safe and efficient in terms of the procedure with rotablator. And I also believe we also save, because using the wire, the rota wire, well, it's hostile, it's difficult. We can break it, it's more expensive. We will need to replace it to then do an atherectomy. That's one point about the lateral branch. This case, the rotablator, that doesn't happen very often because of the technique itself. This carina shift, this flag shift, as it is not so much involved, it will be otherwise very difficult. Another point that I would like to mention, to underscore, this has to do with my personal experience. I'm changing the way I use rotablator. Some basic points I use in my daily practice. I have seen lower complications in recent times and more tolerability by the patient. The procedure is softer, especially, so even if I use high rotation, 180, 190,000 RPMs, I decrease the runs. I do short ablation, really short, 7 to 8 seconds, instead of 15 to 20 seconds that we traditionally use. That's recommended. I'm using shorter, less time, so we would need more steps, of course, but with shorter activations, very fast, real fast. Another tip for the fellows here, before doing atherectomy, saturate the receptors of microcirculation. I do that with vasodilators, nitroglycerin, and also use adenosine. Before starting the atherectomy, what we can do, if we're using a microcatheter, when we go through the lesion, we position the microcatheter in the distal bed, in the case of the anterior descending artery, and then we do vasodilation, nitroglycerin, adenosine. The patient tolerates that very well, and the side effects are just a few. So this decreases the incidence of non-reflow during the atherectomy. These are just some tips I wanted to share with you. A microcatheter, and then I exchange the guide wire for a support guide to advance in the intravascular image to determine then if I have to advance with a stent. I can use that without a rotablator guide. I'm going to show you what I found in the anterior descending artery in this location. We'll see the real diameter, the amount of calcium there. So I'd like to share that with you. Eccentric, concentric calcium, which is the lumen area, which is the size of the vessel. How does IVUS behave to visualize the origin of the diagonal? And what about the calcium? Is it against on the other side of the diagonal? That gives us a lot of information to then decide on the approach, the type of plaque, calcification, concentric plaque, eccentric, proximal distal diameter, and then what happens near the main, in the circumflex, and in the main itself. So in conclusion, the distal diameter was 2.9, proximal was 4.0. There's diameter mismatch. For plaque characterization, more eccentric than intrinsic. The MLD 1.8. So what technique would you choose in this case after plaque modification, after using the rotablator, after using the IVUS, post-rotablator? Would you use a 3.0 balloon based on the IVUS and then modify the plaque? Because if we don't modify the plaque very well, even if you place a stent, it will be under expanded. Carlos, what would you do in this case? I would use also cutting balloon at least at the height of the bifurcation. I believe it's a point where there's a more severe kind of calcification. There at in the region of the carina, you see, there's about 180 degrees of calcium. Rotablator does not provide the chance to visualize. It's not very good. And let me measure just with the naked eye. 1, 2, 3, the anterior descending artery in the area of the carina, almost 4. So being conservative for the distal part, we could use a 3.5 cutting and 4 for the left anterior cutting, 3.5. We could use that in the carina of the bifurcation and also adjacent to the bifurcation in the upper region. For the more distal part, there is 2.6, right?
Não tem.
Bom, se não tem cut balloon, então eu usaria balão
If
não
we don't have a cut-in balloon, I would use an NC balloon additionally, so as not to exaggerate with the diameter, and I would use high pressures. I would use an NC balloon at the height of the carina.
logo acima, isso, logo acima da bifurcação.
Antes, Carlos, antes de hacer el cutting balloon o balón no complaciente.
Carlos, before the cut-in balloon or before the NC balloon, let's see the upper subdivision. I don't want to go where the problem is the angulation. It's hard to get there. Hard to get there to the upper branch. The question is, did you see the eyebrow sign at the level of the bifurcation? Do you consider that when you do IVUS, the risk of lateral branch occlusion? I didn't understand the question. Okay, now I understand. Yes. Important information, yes. Well, the angulation, we can come up with a surprise with a provisional technique, and we can cage this diagonal arm or branch. That would be worrying. As Lucio said, I would protect the diagonal. Another more advanced technique, well, a strategy that I've been using for some time now would be to cage a balloon, place the stent in the main, and if the lateral branch is involved, we would recover the flow and we would gain time. We can buy time to then see what we do. I have a question for Lucio. In your practice, after using the rotablator, do you like to do imaging to see the effect of the ablation, or you simply do predilation with balloon to feel the vessel, to see whether there's symmetrical expansion, or you prefer to see, you look for some sort of calcium fracture if you were able to modify the plaque? Sometimes it's harder to assess. Before preparing the plaque with a non-compliant balloon, but in these cases, I tried to see the calcium after rotablator, and I did it as an educational strategy. But in practice, I would try to pre-dilate first and then look for the image. I would not do what I did in this case. In this case, I can see that the calcium is again the origin of the diagonal branch. So by looking at the diameter, I would like to dilate with a non-compliant balloon, but very aggressive, 18 atmospheres in the main vessel, thinking that the possibility of occlusion was low because the plaque is opposite. When I will move ahead, so the idea was to place a stent in the anterior descending artery, not in the diagonal. And this is what we found. So this is the answer. Provisional stent, non-provisional stent. Most of you are thinking probably about provisional stenting. We always have to try to use as less metal as possible, except when if we do posterior kissing, where the flow is under TIMI3 or the function is at 30%, or dissection involving an important diagonal area. But I will not do stenting in that inferior lower diagonal, and I might involve the upper subdivision. I'll try to move ahead.
Podemos, a ver si se va la votación.
Let's see the votes.
Vamos a avanzar.
Acho que a maioria votou por o provisional, não foi, Lúcio? 94%.
94%.
I believe that provisional 94%, most of the votes. 3.38 before the diagonal, an important topic. After preparing the plaque, if the diagonal. We are positioning the stent here. How do I implant? If it were distal, I might affect a much smaller vessel and lead to more dissection in a calcified vessel. In a young patient, I have to avoid a mammary graft in the future if necessary. And then from the healthy to the non-healthy segment. So this is the diagonal in this case. And this is how we place the stent. You see here, the expansion of the balloon is quite well. So it's not under expanded. What tool can I use if IVUS is not available for evaluation? This is the way to see the expansion of the stent. And if it's under expanded, I use it in 100% of my cases. I use the stent boost depending on the platform. Now, this is the situation here. This is the angiogram after stent placement. What do we do now? You see here the diagonal. The ostium is more involved. And I have a coronary wire through outside the stent in the inferior subdivision. So here I would try to see if I can go to the upper branch, how I can recross the stent to the upper area. A very important issue here, the message is like POT, proximal optimization treatment, POT. By increasing the size, as you see here, to then recross later on to the diagonal area, because this wire was out on the outside. The stent placement was with a wire, but here we can use POTs 3.5 by 6, so as not to involve this segment and to involve only the bifurcation and then to the back, to posterior. And here's the maneuver, trying to recross when the cell is already open and not all the stents have the same cell to the upper branch.
Ya teniendo eso, poder
And
retirar.
then you can remove the lower subdivision and then treat the bifurcation. I dilated because the residual lesion in the ostium to the upper division. I did pre-dilation with an NC balloon, but in this case, I found what was below. There was a dissection in the anterior descending artery. And well, you would say, what do I do here? We have the diagonal, the residual lesion below. I placed a stent in this case, according to the distal diameter. And here I did kissing balloon technique, balloon 3.0, 2.5. And this is the result. There was a balloon here, and this can be very many things. Let's see the distal segment of the anterior descending artery. It could be plaque shifting, could be dissection, could be spasm. We then determined what to do with this. On the other hand, say, what do we do here? What do I do now? We can advance because I wanted to know what was the diagonal by IVUS. We had already pre-dilated, and then we are going from the upper subdivision. You see here the upper and lower subdivision in the image, and we can see the ostium in the diagonal, where the stent is already placed in the anterior descending artery. Look here, the diameter in the diagonal at the level of the ostium. And this is telling me that there's a significant lesion with an area under 4 millimeters. Carlos, I would like to know what you would do in this case. Nothing, stenting, provisional stenting with drug-eluting balloon. Lucio, first of all, I would like to underscore an important point of your presentation. To assess the lateral branch with IVUS, it's fundamental, it's essential to do an image of this branch. The lateral branch assessment through the main. If we had all done only an image, I would like to see the ostium of the diagonal. And I would make an estimate because we cannot see an axial slide. We can see that cross-sectionally, and this is an underestimation. So it's key here to obtain the lateral branch image. The way I see it, the result of this diagonal ostium is suboptimal. There's a calcified node, a protrusion with ill-defined borders close to the catheter. This could be a challenge for treatment with provisional treatment. Drug-eluting stent, no, I wouldn't use that because the drug-eluting balloon is very good for drug elution, but the treatment, we have to do the treatment with a regular balloon, and then we have to use a drug-eluting balloon for drug release. Here, the result if the diagonal is suboptimal. I believe that as it is an early bifurcation, I would not like to lose any of the two. I then would insist on kissing, higher pressure, or else angioplasty with balloon, with a long balloon in the ostium, in the diagonal ostium, and then we repeat the kissing technique instead of a tap. I suppose that starting with the drug-eluting balloon is complex because the result is suboptimal. Drug-eluting balloon, except when plaque preparation comes first with good angiographic result with an NC balloon in the diagonal branch, kissing balloon, kissing technique. And then if it's okay, then you might think about a drug-eluting balloon. But otherwise, or if you have a residual lesion, more than 30% on a dissection or TIMI under 3, then I would say stent. In this case, it was not so. Interesting. It's interesting to see the voting. 33 drug-eluting balloon, 44 TAP, none, 22. I would follow the same strategy as Carlos. I would use an NC balloon, knowing that eccentric calcium can mitigate the effect of the balloon, the NC balloon. So the balloon will exert pressure against the non-calcified wall of the artery, and then preparation of the lesion is not adequate. So we could use the physiology, coronary physiology in this particular setting to see if we invest, let's say, in the diagonal ostium or not. This diagonal is key. It's unique. It's bifurcated, as Carlos said, and I would not like to lose it or leave a suboptimal result in the origin of the diagonal. Perfect. Well, we saw the voting. I'm trying to see if we can move ahead. Well, here in this case, this discussion is so interesting. So I did insufflation, alternate insufflation of the diagonal 3.0 with the diagonal, and then as we had a good result, we could visualize the diagonal again. And this is the IVOS-based result, Carlos. There on the left, in the upper quadrant, you see the ostium, and you see the left anterior descending artery. The use of a drug-eluting stent was that. Well, that's one topic. Another thing is to see what's here. I took the wire in the floppy area, floppy side, just to see whether this was a spasm, dissection, or what. We might say, well, I can do IVOS, and then that's the answer to my question. I was rather scared in this kinking area, as you see here in the descending artery, if the catheter may generate more damage in a thinner vessel. Of course, how would you manage the distal LAD? Non-stenting balloon, drug-eluting balloon. Well, I used a conventional balloon, non-compliant, NC based on IVOS, and then I place a drug-eluting balloon that I use it widely in the distal anterior descending artery so as not to place more stents. And this is the result with the drug-eluting balloon. This is my own experience. We can discuss about it. And then I'll show you the anterior descending artery after the procedure without a stent in that segment that you saw with a sort of spasm dissection. 8 atmosphere long insufflation with an NC balloon, the good results. I want to finish this up with a drug-eluting balloon. This is what I do in my daily practice. And this is based on IVOS. This is the final outcome. Can you go back one slide, please? I would like to emphasize, congratulations, the result is excellent, but I would like to also call your attention In all the ultrasound slices, we can see a symmetrical stent. Apart from the severe calcification, in this case, the stent all the time with a circumferential format, no eccentricity here. And this is related with the adequate preparation of the lesion. So I would like to underscore, to emphasize this point. We have a severe calcium arch, 180 degrees. We see a circumferential format of the stent. Really a spectacular result. Congratulations, Lucio. These are complex. We should use as little contrast as possible. Sometimes in the case of kidney failure, I use road mapping, coronary road mapping, rotational angiography to visualize in one injection from the cranial right oblique to the anteroposterior left. We can use stent boost, plaque optimization, IVUS guided assessment. We have to do RotaPro because no balloon could go through, or any other device, not even IVL. And then guide a strategy based on IVUS. Then let's use RotaPro. Let's do stent boosting to see if the expansion is okay and symmetrical. If IVUS is not available, then the use of professional stenting if necessary, and drug-eluting balloon in the diagonal and the distal anterior descending artery as other tools available instead of using stents all the time in these cases. So I invite you, if you want to participate in the Latambif registry, you can send us an email to participate. It's an open registry. Today I had very good news from Ricardo Costa. Brazil is actually joining the registry. Congratulations. Another point is that the 1st and September 1 and 2, we will have the largest event in Latin America on coronary bifurcations in Sao Paulo, Brazil. And we will be interacting with Ricardo, with Carlos, Evandro, and many other experts on the world and Brazil. We cannot mention them all, of course, but I simply wanted to tell you about this event. It would be great if you can participate because it's the event on bifurcations in Latin America, the largest event, sponsored, of course, and supported by SOLACI, by Latambif Club, and from all of us, because we keep on learning from you all. So, Nico, I would like, Nacho, Carlos, Evandro, I would like you to make some final remarks. Any comment, any final comments? Well, once again, I would like to thank for the invitation. The case is really very educational, many points to learn from, for discussion, even for exchanging opinions and experiences. This has been a master presentation, a pleasure to see all my friends, in spite of being virtual. Well, Nico spent some time with us here in Brazil. A great pleasure to see you again. Congratulations on the initiative. Wonderful, very important to have this kind of cooperation and collaboration in Latin America for growth and development together. Thank you very much. Also, I would like to thank once again, thank you, Lucio, Marcelo, Nico, Ignacio. Thank you for the invitation. To be here is a real honor, as Carlos said, surrounded by experts. The case was fantastic. Lucio, you always do things like this. This is what we all expect from you always, a very educational case. We could even keep on with the discussion. I would also like to thank Latambif. I'm part of the commission and I try to contribute and help. So I hope we can meet again in the Bifurcation Summit. here in Brazil, organized by Ricardo Costa Society. Ricardo Costa is the leader of this meeting. It's a post-pandemic event. We have international speakers in important discussions on the topics that have to do with coronary bifurcations. I would like to invite all the fellows and colleagues to join us, and an honor to be here with you all among friends. I would like to thank the Latambif Club. Thank you for your support in this initiative. I would also like to thank Ignacio Cigalini and Nicolás Zaderenko. Nico is the leader in this fellow corner, the support of SOLACI. He's trying to help, and he's trying to help all the physicians who are starting in this interventionist cardiology world. This is a meeting point. Today is the first case, but we will be dealing, let's say, every month or every 2 months, we'll try and meet. So Nacho, Nico, maybe some closing remarks. I would simply say thank you. Thank you for your comments and the experts. It was very interesting for all the fellows. We have all learned. So I'm here waiting anxiously for the next meeting. Thank you very much. I insist. ProEducar, well, we have a place for you, for the fellows. You can send your cases, and you can exchange information there in the ProEducar site. Some cases are good for discussion, for presentation in the webpage. Other cases can be discussed in these meetings. That's the idea. Then we will send you a survey. So could you please fill it up? It's just a short survey to know more or less your opinions and what we have in Latin America. Thank you very much for your participation. Well, you all stay till the very end. Thank you, Carlos. Thank you, Evandro, Lucio, and Marcelo, who couldn't join us. Finally, Nico, Wonder Medical is an excellent system. Everything we're doing is recorded in the Latambif Club in Wonder Medical, and you can watch it in Portuguese, in Spanish, or in English, because there's simultaneous translation. So you can repeat and you can reevaluate and reassess and watch it again. So this topic and all the other topics we will be dealing with in the future. Thank you, SOLACI, for the opportunity, the support. ProEducar, thank you very much. Good evening, good night. Thank you.
Ciao, ciao.